going to have a bit of a roundtable discussion on identity management of both provider users as well as patients for health information exchange. So focusing on the ID proofing and authentication issues related to providers exchanging health information both among themselves, but also with patients increasingly. We know, for example, for stage 2 of meaningful use, which will begin for early adopters in the meaningful use program in January of 2014, there is the expectation that patients be able to view, download, and transmit portions of their records. That obviously raises identity management issues. Similarly, HIPAA privacy and security rules have always placed expectations on provider organizations that are covered by those rules to do identity management and authentication, but there aren't any specific levels set. The expectation is that organizations will approach this issue consistent with their risk assessment in terms of how they handle this. And certainly I think the sort of expectation that we've been operating under is that we have to basically trust organizations to do the identity management and authentication of the individual users of their system, and that trust is expected to sort of hold for exchange of information across institutions. And I think as we are increasingly digitizing health records and building and using the infrastructure for exchange of information, can we still rely on those assumptions? Can we still have sort of a set of expectations where each institution, each provider practice is expected to sort of make their own good judgment calls with respect to how they conduct identity management and authentication? So I'm Devin McGraw. I'm the director of the Health Privacy Project at the Center for Democracy and Technology. I also co-chair the Privacy and Security Tiger Team, which is a subgroup of the Health IT Policy Committee. We've been we have put some recommendations on these issues, and we'll talk a little bit about them. But we'll also spend some time with some panelists up here talking about the issue of identity management and authentication, both with respect to provider users as well as with respect to patients. But before we sort of kick off the session that we're doing today, I want to ask our panelists to introduce themselves. One of our panelists, Beth Franchi, who is the director of the Veterans Health Administration Data Quality Program, is with us by phone. Our connection to her is not as ideal as we would have hoped. It's apparently one-way, not two-way, unless she's able to hear us on the web. So we'll see how that works. So rather than pausing for her to introduce herself, I'm introducing her to you now. But I would like for the rest of my co-moderator to introduce himself as well as our panelists, and then we'll start the program.
Thanks, Devin. My name is Walter Suarez. I work for Kaiser Permanente, and I am the co-chair of the Health IT Standards Committee, Privacy and Security Work Group, which looks at the policy committee recommendations and then looks at recommending the standards part of that. So we'll talk a little bit about that.
Paul.
So good morning, everybody. My name is Paul Uhrig. I'm the Chief Administrative Officer of SureScripts. Just to put it in context of what we do and my interest in this topic, SureScripts is the network that has connected pharmacies, prescribers, payers, and other clinicians for the electronic exchange of information. So about 69% of office-based physicians, 93% of pharmacies, and most of the major payers are all connected to the network. And we process about 50% of the prescriptions in the country right now. So we have probably about 2 billion messages of prescription, medication history, and other information flowing through the network. So obviously ID management is very critical to us. Thank you.
Thanks, and I'm Peter Tippett. I'm the Chief Medical Officer of Verizon and run the Verizon Innovation Incubator. Prior to that, I ran CyberTrust and Verizon's acquisition of the security company at CyberTrust, which is now a Verizon entity. CyberTrust in Baltimore and VeriSign were the three big names in identity in the early days. CyberTrust and Baltimore are both now Verizon. VeriSign is now Symantec. That's how the connection to identity comes here. So I have the enviable position of running the healthcare practice for Verizon and historically the security and identity practice for Verizon. And that's the connection. I'll have some data for later today from some studies we've got, but that's enough for starters, I think. Thanks.
That's terrific. Thank you. As I mentioned, we're going to start with a little overview of some recommendations that the Health IT Policy Committee and the Health IT Standards Committee have come up with in this space. We actually had two joint hearings on this issue. One on provider identity management, and the other was on patients. The one on providers was live, the one on patients was web-based. But based on what we learned from that hearing, which had a number of folks testifying, including actually Verizon and SureScripts and the VA, we as a policy committee came up with the following recommendations. And these are very summarized. There's actually complete transmittal letters of the full text of the recommendations online if you're interested, but I wanted to hit the high points for you. We acknowledged that, notwithstanding the discomfort, I think, among some that we're still probably relying a little too heavy on individual institutions to sort of do the right thing in this space. We nevertheless see that, pretty much think that that's the situation that we're in, and probably one that we might be in for the foreseeable future, absent a sort of national identity management strategy or set of solutions. So provider organizations are going to have to continue to ID proof and establish authentication for access to medical records for their individual users per HIPAA. But having said that, the fact that there aren't any sort of very clear standards for providers to aim at was something that we wanted to try to address. So the recommendation that we made was that by the third stage of meaningful use, ONC should move towards requiring multi-factor authentication, ideally meeting NIST level of assurance. 3, for remote access to protected health information, and we defined some circumstances that would characterize remote access, but it's essentially sort of outside of the control of the enterprise and unsecure, or where security is questionable. Entities, of course, under the security risk assessment should still be identifying other access environments where additional authentication ought to be required as a matter of institutional policy. And we acknowledged that the technology was really pretty rapidly changing in this space. And, it was not our desire to sort of cement in one-size-fits-all types of solutions. We're very much aware of the efforts going on with respect to implementation of the National Strategy for Trusted Identities in Cyberspace. We were very enthusiastic to hear about the prospects for that, excited about what it might do for the identity management space, but there didn't seem to be anything that could be deployable today, much less necessarily from our predictions by stage 3. So we asked ONC to keep an eye on those developments and to be sort of looking at this as an evolving issue that would need some attention to be paid to it. On the patient side, we sort of acknowledge that there is, that this is a bit of, not that it's not a tough issue for providers, but it's a tough issue for patients in part because we're trying to encourage them to access their medical records online. So we want to do proper ID management for them, But at the same time, we don't want to set the bar so high with the same set of expectations that we might have on professional staff that it makes it hard for them to be in the game. And so we really were very intrigued by what we learned about what was going on in online banking. Probably those of you who do security in that space might be cringing right now because it's not a perfect solution. Having said that, those of us who know where we are from a healthcare standpoint, I think in general we agreed as a policy committee that that might be an improvement. Something beyond username and password, but probably not at level of assurance 3 from an authentication standpoint. Something that looks very seamless to the patient or consumer, that is a lot like what many of them have become accustomed to with online banking. We called that, I don't think we coined this term ourselves, level 2.5, somewhere in between, but better than just a username and password for authentication. And again, another space where keep an eye on where the puck is going, what's being developed out of NSTIC and those pilots, and what can we leverage. So I'm going to turn it over to Walter to talk about how the Standards Committee has handled these issues, and then he's going to start us off on a panel, and we're going to dive into the provider identity management issues first, and then we'll move to patients, and I'll moderate that section. Thanks. Walter?
Thanks, Deb. So I'm going to move very quickly to really go to our panelists. And the reality, I guess, from the perspective of the Standards Committee is we dive into the technical standards. We leave the policy decisions to certainly the policy committee and the directions to us. So the Privacy and Security Work Group has looked at this, and certainly from the patient identity management, the main thing is really that continues to be a significant issue. The need to identify patients for various reasons exists, and the lack of a reliable method to identify them across organizations and sometimes even within organizations is creating significant challenges to maintain care delivery, to improve care delivery, particularly now with a much more bigger emphasis on care coordination across disparate systems and ultimately healthcare quality. So we understand that is still a major challenge, yet we know that we don't have really in this country a unique patient ID or identity, and that we live within that constraint in the industry. So the main recommendation have been basically to continue to allow the progress and innovation to occur in this area and not define yet a specific mechanism of pursuing this. We're pending the definition and the decision from the policy committee in terms of the next stages of development of this area of identity for patients. But at this point, the Standards Committee has not yet made a formal recommendation really on which technology or what specific methods to use. There is also on the provider identity side, certainly we have followed the direction from the policy committee, and the expectation is that the direction will be certainly the use of a level of assurance that reaches at least a level 3. The discussion that we have had is there might be some adjustments to be made based on the role of the provider, whereby, for example, in some instances, certainly where physicians have access to and have full control of a record, they certainly might need to have that at least level 3 of assurance, whereas non-clinical staff that might have limited responsibilities and control and access to the records might be able to handle or be able to use a level of assurance of 2 or something in between. What the point is basically is that the EHR technology will need to be configurable to enable these various levels of authentication and identity proofing based on these needs. And certainly when you add on top of it the patient identity and the need to identify the patient before they can access their health records, that also makes a call for a EHR technology that is flexible to allow the different levels of assurance. Certainly the biggest part of this is, in terms of the direction, is NIST, and the benefits that, INSTIC, I suppose is what we call it, right? INSTIC or NIST, the benefit that it offers and the direction that it's taking us. And I think the expectations, again, based on the direction from the policy committee, Meaningful Use Stage 3, would be that the EHR would be required to support this two-factor authentication in various modes and permit one of the factors to be perhaps even a third-party solution, and this is something that we'll talk in the panel. Certainly in anticipation of the INSTIC credential is becoming available. We are somewhat concerned, I guess, or not sure about the ability of INSTIC to be fully operational by the time that Meaningful Use Stage 3 becomes a reality. And so we need to be mindful of the progress and the transition that will happen in the industry with respect to the adoption of INSTIC standards. So I think that was mainly what I wanted to cover, and I think now we're going to really turn to the panelists to discuss these two items. And so I'm going to start with posting a few questions about provider identity, and then Devin will be facilitating the discussion on patient identity. So the biggest question, really, I think, that we face with respect to provider identity is how to implement an identity-proofing system, basically the ability for prove the identity of a provider and their staff whenever is needed, and then to, once that identity proofing has been assured and achieved, then authenticate that provider every time it contacts the system. So considering those two elements, I think the first question really to our panelists is, what is their current approach to identity management for providers? Basically, how do they handle today the identity proofing aspects of identity management and then the authentication aspects of identity management for different types of providers? And certainly we have a great group of panelists that have a lot of experience in this area. So I'm going to turn it to our panelists to address that question. And I don't know if we can maybe hear first perhaps from Beth from the VA. She doesn't do provider. Oh, okay. We're going to skip Beth and then go directly to Peter and Paul. So who wants to?
Sure. Well, let me tell you sort of the approach that we take at SureScripts. To give you a little bit more context as a network, we have about 338 electronic healthcare vendors who are connected to the network. So it's those vendors who basically have the relationship with the prescribers who are prescribing over the network. So it's always been our approach that the vendors need to know their customer, and it's their obligation to ensure that prescribers are on the network, that those who are on the network are known to them and are prescribers. So as the industry has evolved and as the bar has been raised ostensibly, we have a policy that the vendors need to show that they have at least a NIST Level 2 identity proofing system in place. And, the way we think about this is in the industry, I put the providers who are connected to us in different buckets to the point of what one size does not fit all, right? So we may have very well-developed, large medical institutions like a University of Pittsburgh Medical Center, a Johns Hopkins, enormous security departments. They obviously have credentialed all of their physicians and have policies and procedures in place. So there you have a high level of assurance of who you're dealing with. Then you have, when we talk about vendors, we often think about the large vendors. We know their names, Allscripts, Cerner's, and the others. Also it's incumbent on them to make sure they are imposing a NIST Level 2. But as the industry's evolved, we also have smaller vendors. People who are implementing mobile electronic prescribing applications. And part of the challenge is to make sure they're educated as to what the standards are. Again, our view is at the moment NIST Level 2 for e-prescribing. So that's the way we've approached the ID proofing for e-prescribing. I should note that for controlled substances, there the government has imposed a NIST Level 3 for ID proofing and a two-factor authentication in order to e-prescribe a controlled substance. So by virtue of that regulation that was put in place about 3 years ago, we would see hopefully the entire prescribing community and physician community and other providers moving towards a NIST Level 3 ID proofing and authentication.
If you don't mind, I'll do just a tiny bit of clarification and background to give you a little bit of data. I know that we're throwing around 2 and 3 here, so let me just give you a layman's 2 and a layman's 3. NIST goes from 1 to 4. List 1 means anybody who claims to be Mickey Mouse is Mickey Mouse. It just, whatever your claim is true. So if you claim to be pstippett99@gmail.com, you're pstippett99@gmail.com. It doesn't associate the name with a person. It's a claim of basically user ID. NIST Level 1 is made to get that to happen again with relative assurance. NIST 2 hooks that name, that identity, to a person somehow. There is some process that ties that to a real person somehow. NIST 2 does not require two-factor authentication, neither does 1. NIST 3 ties that person to a identity that includes at least 2 government-issued identities and some kind of evidence of permanent address, like a bill from your power company or cell phone, phone company or whatever. NIST 3, by default, requires two-factor authentication. And NIST 4 does all of the above, but it adds background checks and the ability to do biometric identification, like fingerprints and retinal scans and things like that. So just so we have that all laid out. And I know Elizabeth, who can't speak very well at the VA, was saying this is all kind of silly. Everybody at the VA is authenticated at NIST 4, right? And in the government space, we all kind of deal with that. At NIST 4, we tend to have smart cards that carry that identity around like our military do, like the White House folks do, like the people at the VA do. So that's the background. Many, many countries have smart cards handed out as part of their national ID card. And in 25 countries, Verizon provides that system to the country, like Belgium and Hong Kong and Singapore and lots of others. It is a standard PKI-based system. PKI is the root of all of these NIST levels, and the way you represent them when you're trying to move them around is through certificates, just to get the nomenclature right in case nobody's got that nailed. The certificates are identical to the certificates that you see when you log into a bank and see the lock that's locked. In that case, it's the bank that's proving to you that it's really Bank of America or whatever, okay? But you're not proving to the bank anything. That's the part of the background. Now, I mentioned that Verizon has been doing information security for 20-some-odd years, and Verizon is the historical part of Verizon that has to do with security is mostly around cyber trust and Baltimore for identity. But Verizon also does a whole bunch of risk management programs in the world. And one of the things that we publish every year is this thing called the Data Breach Investigation Report, the DBIR. If you have not, this is free, and you don't need to tell us your name. If you Google DBIR, you may download this for free. It is by far the most downloaded thing at Verizon. It's also the most downloaded document in all of security in America and most of the world. This has every case. This is pushing the 10th year of data. But this is how computer crime actually happens on Earth. Right? It is, this year it's 617 or 600 and something actual cases where Verizon people did the investigation, mapped all of the things that happened in that computer crime to all the possible things that could have been wrong, including identity. This also includes another 12,000 cases where we have good data but not perfect data from Secret Service and a whole bunch of other government agencies around the world that do computer crime investigations for their purposes. We all use a framework that we published and is open source called VERIS. The VERIS framework is VERIS. If you Google VERIS or DBIR, you'll get all the stuff I'm talking about, all free, all open source, right? The complete report for many years running, including a healthcare drill down, is available if you do the DBIR. Now, let me just give you the data, there's tons and tons and tons of data in here. We can figure out the power of any control, of any countermeasure. We can figure out the frequency of any event. As you know, HIPAA basically requires a risk assessment, and then you're supposed to do the right thing, depending on your risk assessment. Well, risk assessment is not a vulnerability assessment. Risk assessment combines the vulnerability with the actual frequency of attacks. I'll give you an example. Our vulnerability to getting hit by a meteor and dying from it is pretty high, right? If we get hit, we're dead, right? So that would be a problem. You're all good with that? Does that mean the risks of meteors are high? No, because the threat rate is low. The likelihood of the meteor coming and hitting you is exceedingly low. Risk is the combination of threat, which is a frequency, and likelihood of dying, which is a vulnerability, right? The two multiplied together is what gets you risk. If you want to Google my name, Tippett, or risk, you'll see the equations that are very simple that apply to technology that relate to this, okay? So it is not a problem necessarily to be vulnerable to something if the attack couldn't or doesn't happen. One thing that's in the DBIR is a matrix of all possible kinds of attacks and the ones that have ever succeeded on the planet Earth. We tend to spend most of our money on the white space where there have never been a successful attack, and we tend to not spend our money on the red space where it happens all the time. That is if we merely put the emphasis on the right syllable, you got to put a pause in there. I tried that in China, it doesn't work. If we merely put the emphasis on the right syllable, we can reduce risk to our enterprises and to the healthcare ecosystem by at least 3 or 4 orders of magnitude without increased cost, merely by following the simple things that we know work. Now, as regards identity, we get about 100-fold risk reduction in identity in all of security, of all of attacks, of all of hacking, of all things that relate to any losses. We get about 100-fold merely by going from one-factor authentication to two-factor authentication. The risk here is not in identifying who the person is and proving for sure that that's really Betty Jane Boop, right? It is that once somebody claims to be Betty Boop, that we have some sense that once her identity is stolen, it can't be reused by somebody else. Because the vast majority of attacks, both inside of healthcare and out, that are successful are where the identity was stolen and replayed somehow. Stronger passwords don't make it stronger. I realize this is completely anathema to what we've heard for 30 years, but stronger passwords, once you get past 4 or 5 characters, aren't any stronger. It's like making your seatbelt stronger. If you make your seatbelt go from nylon 3-inch strap to titanium mesh, and it's 1,000 times stronger, you could pick up the building with it, but it wouldn't reduce your likelihood of dying anymore in your car. You definitely have a stronger seatbelt. So stronger passwords are definitely stronger, but they don't reduce risk, right? Because we've reached the plateau of the power of a password. So if you want to increase the power of a password, the way you do that is by adding something else. That's how we increase the power of a seatbelt, right? We don't add a stronger seatbelt. We add airbags, and we add resistant brakes, and we add better signs and better training, and on and on. And all those other things add up to the maximum power that the seatbelt has. This is easily proven, by far proven, long since proven, endlessly proven in security. We just refuse to do the step of adding the second factor. Largely that's been relatively expensive and cumbersome and painful because we've put chips on cards and chips don't get read by our iPad, and it's kind of a difficult thing. And so NSTIC came along. And NSTIC worked and created slightly separately but slightly the same a standard called ICAM or FICAM. ICAM or FICAM. The F is federal. I can't tell you what the rest of ICAM is, except that the I is identity, and AM is access management. So anyway, it's an identity standard which, oddly enough, maps identically to NIST 123.4. Kind of cool, but it allows you to do it without the having a certificate involved. So we now have a standard, a federal standard called ICAM, which is in place, and both we and Symantec have achieved ICANN certification. I think we're the only ones who have, but it's a tough standard. But it allows you to get to NIST 123.4 with or without certificates, right? So Verizon has deployed, with SureScripts, systems like in New York State that can get everyone to get a NIST Level 3 where no one needs to show up in front of a human being with two government-issued identities. It can all be done online. This is done in the tens of millions of scale or hundreds of millions of scale right now, and it's deployed and work. It's not running in New York. We've all got it deploying, but we have deployed it in 18 places around the world so far. Works fine, meets all the standards of both ICAM and NIST 800 and LOA 3 for standard stuff. So this stuff is in place and does indeed work. And the last thing I'll say, I realize that I'm kind of rambling, but I think the background might be a little bit helpful, is that if you think of level assurance 1, 2, 3, there's really two parts to that, and we've mentioned it here. One is the question of proving that the person is really the person they say in the first place. That's called the registration step, or the IDP, the identity proofing step. That gets harder and harder as you move from 1 to 2 to 3 to 4. With 4, it has a background check and all kinds of other things. With 3, it's two people, two different government-issued identities, and so on. With level 2, it's a claim. And with level 1, there's nothing to test anything. That up through level 3 can all now be done online without anybody showing up, so it can be done less expensively. And the second, but I will tell you, having the data and the analytics, and by the way, Bill Braithwaite, who wrote HIPAA, has teamed up with Verizon, and we're going to write a password identity white paper in the next 2 months that will summarize everything I'm just saying now and all the data that supports it with two kinds of risk analysis. One that is the analytic part of it, the sort of why it works this way, right? And the other one that just takes the data from the market and says, and here's what the market data shows. So we'll be publishing that as well, just to reinforce what I'm saying now. But it turns out that the LOA 3 kind of identity proofing doesn't get you much risk reduction. It could. You could imagine how it would be useful. But in terms of real attacks to real people, to real entities in the real world, the biggest problem is the verification of that. That's the same person coming back again. And that's the authorization or the authentication step when you log in a second time, a fourth time, a 20th time. That's where the two-factor happens. And I know we mentioned NIST LOA 3 and NIST 800 two-factor authentication requires particular kinds of second factors, some of which are okay and some of which are not, and that's fine. That's the way the standard reads. The only thing I would suggest we change about the standard in the future is that we have all kinds of ways now, way beyond the sort of biometric stuff that's been fuzzy in the past, that can get to your second factor. The first factor is usually a password. The second factor is something you have, like a token or a smart card, or something you are, like your fingerprint or your retinal scan or something like that. Many of the biometric factors are not allowed in some of the NIST criteria in a detailed way, and we can talk more about that. But there's all kinds of other factors that our modern world gives us, like our geolocation, for example. If your phone is in the same place as your PC, which is easy to tell nowadays, and your phone is registered to you, and you've done a NIST Level 3 authentication and registration step, like with the phone company, when you buy the phone, they get your identity and your mailing address and your driver's license and essentially all the stuff that leads to that registration step. It seems a pretty good bet that it's you, right? It may not be quite as strong as your fingerprint, but it's still very useful. And there's a dozen, in Verizon we have 14 things we call form factors, only 5 of which are approved by NIST for two-factor authentication.
Yeah, thanks, Peter. Thank you so much. This is a great way to really introduce this topic, this concept. I think one last question before we turn to the patient ID, and if you can give a quick answer, that would be really appreciated. I think that the part that really comes up mostly is how does this really apply to healthcare? And Peter, you particularly gave a big picture of how this can be scaled out to the world, basically to every consumers, even not just individual physicians or lab technicians or whomever is going to interact. So, really, when you boil it down and when you think about the current healthcare environment where physicians come and log in and others do the same thing all the time and all that. And then EHRs are going to be expected to be certified in some play at some point of time to be able to interact with this type of with this type of technologies that provide levels of assurance. How do you actually see that the EHR interacting with that? And for both our speakers, I guess, is it something that you see it really dependent on a third-party provider of this type of tokens and this type of methods to provide levels of assurance of like 3 or around 3? Or is it something different? Is that the solution that we're driving down?
Well, I think the key here is the interoperability of these systems, right? And ultimately the adoption by providers. I mean, I think, this is going to take some time, and I'll take it back to the DEA rule that I mentioned earlier, where we're about 10 days away from the 3-year anniversary of the DEA issuing a rule that imposed the NIST Level 3 and the two-factor authentication to prescribe controlled substances. So, the issues that the industry, so let me just give you some statistics, right, as to what is adoption almost 3 years later. So I mentioned we have 515,000 prescribers on the network. 1,400 are certified to do e-prescribing, right? 58,000 pharmacies on the network, 14,000 are certified to receive a controlled substance meeting all the security. We process about 4 million new prescriptions a day. Over 3 years, there have been about 120,000 prescriptions for controlled substances. So, what we have to do is sort of overcome those barriers. Now, for the DEA rule, it was more than just two-factor authentication and ID proofing. They put in place many other security measures, all, very good measures. But the challenge is getting this process into the workflow of physicians so they can use one identity for multiple applications so that they don't have to use a fob for e-prescribing, a different fob for this, a different fob for that, and to integrate these all for maximum use in the workflow. And so I think ultimately, we're going to have to rely on some third-party vendors and others to make this interoperable. The project that Peter mentioned that we're doing with Verizon, achieves that by creating a trust broker mechanism so that multiple relying parties can rely on one confirmed digital identity.
Yeah, thanks. I agree. Anybody can spin up a password, so you don't need third parties to do that. Unfortunately, passwords are somewhere past 80% of all things that go wrong on information security, and if you count the number of records that are stolen, it's something past 99%. So it's if you could fix only one thing, you have all possible technologies or policies or procedures to apply to information security in an enterprise or a government or whatever. If you could fix only one thing, by far the strongest thing is to fix passwords. Firewalls and intrusion detection and all other technologies combined can't do as good a job of improving risk as getting better identity. This is just the data. I'm not selling. We sell it all at Verizon. We'll gladly sell you all the other stuff too. But But the single most powerful thing that we need to take a step on is stronger identity. The good news about the data that you just described on which physicians have the ability to do second factor and which pharmacies have the ability to receive it is that if you gave those stats just 6 months ago, we've more than doubled just this year.
Wow.
We have hit the inflection point of adoption. Verizon released an app almost a year ago that can tie into any electronic medical record in the back end and let anybody post the prescription. And what happens is it's not signed yet, so it comes as an unsigned thing. But it gets sent to the doctor's phone, on any network. It can be the other guy's network, doesn't matter, works, right? And the doctor merely has a phone buzz. They pick up their phone, that's one factor of authentication. They log into their phone, that's another, and they see the prescription. And they type yes, yes, yes. Now, NIST has us do another approval at that point we actually do the password thing twice. Doesn't seem to actually be required, but we got it approved. So this does work, right? And so it is possible to have a fully deployed EMR for Schedule II drug e-prescribing. We've also deployed and are very rapidly deploying the receiving end in all the pharmacies in the world. There's lots of that happening now. So that as these things come together, as we just described, Paul described, there's more than just LOA3 in that. There's digital signing and some other levels. The document itself is signed. There's more things going on. But those kind of infrastructures are the same things that we use to do military authentication and nuclear launch code verification and wire transfer verification. So it is an old technology, this PKI. It's well deployed. Every operating system on the planet knows how to deal with it. So certificates are understood by the technology part of the world. It's the process and people part of the world that we need to get working.
Thank you. Thanks, Mike.
Yeah, so let's turn to the issues involving the ID management for patients. And again, we really focused on this issue with respect to doing ID management for patient access to, say, a portal or what's called the view, download, and transmit functionality for stage 2, as opposed to consumer ID management issues that might occur just sort of broadly in an online ecosystem. And I want to turn to, and I hope we can do this technologically, I want to turn to Beth Franchi from the VA. We had her testify about how they are credentialing veterans for My Healthy Vet as well as the blue button functionality. So it's not just for a view into the record, but also the capability to download and then, also hopefully in the near future to be able to sort of send that record elsewhere. But I'll let her sort of speak to the challenges that they've faced and how they've managed to make this work. Can we get Beth on?
So can you hear me?
Yes, perfect.
Because I'm having some challenges, but anyway, thank you for having me today. Try to keep this brief. Kevin, thank you. As you mentioned, we do credential our veteran for My Healthy Vet, as well as our what we call our e-benefits portal, and we use the level credential, which means we do in-person proofing at the required NIST insurance for level 2. We have a host of individuals who have that, what we call Healthy Vet, a premium or authentic account, 1.2 users who have a level of approximately 800 VA blue button users, and just an idea of how the downloads are from the button. We have about 3 million files downloaded. We also have a whole host of both personal record information and electronic record information, as DOD's military health information that the individual has the right to have access. And we have all 650,000 100,000 patients usually call our secure mess. We have kind of leveraged our own credential server, but we also have an infrastructure, our authentication infrastructure, where when our credentialed service provider and then leverage that, able to utilize applications, keep that chain of trust. We know who the individual is. And I don't know this or not, but you all considering, or the health IT looking at low 8.5 part of NIST. I think Peter mentioned vanilla flavor.
I'm going to... Beth, I'm afraid we really can't hear you very well, which is unfortunate. You know, when I don't know where David Holtzman is. I can't see him. We might just have to ask Beth to. Unfortunately, we can't really hear her very well. So I can't summarize the VA experience. I'll turn to Peter in a second to see if there's anything else he wants to say about patients. I will say that when we had the hearing, some of the issues that were raised there were, obviously there are lots of opportunities to do in-person ID proofing, to credential a patient, to use a portal through, a provider office or a hospital, because patients do routinely come in to the office for healthcare. But at the same time, if you are largely someone who is healthy, who doesn't have to visit the doctor often, or you're living in a rural or remote area where coming physically into the office in order to be identity proofed for in order to get credentials into the EHR system is sometimes difficult. So we, in fact, acknowledge that some remote ID proofing would ideally need to happen. This might have to be done using a sort of knowledge-based authentication provider. Patients will need to be educated about what that means, because it sort of freaks people out a little bit when they call in and they start asking them all these questions in order to ID proof them, and it's on information that isn't necessarily mortgage levels and other transactions that are not associated with healthcare, and they're frequently wondering, why is it that my doctor has this information? Well, the doctor doesn't have this information, but it's the part of the process of proofing. Use of out-of-band confirmation if some of this stuff needs to take place online. And ultimately where we landed was sort of a set of best practices for doing this in the private sector that, again, to balance the sort of spoofing and other risks that come from not doing credentialing well from a patient standpoint, with not setting the bar as high as a set of expectations that you might reasonably have of professional staff, but, for patients who might not have those resources. It was another place where we, again, thought, man, if we just thought of NSTIC like 3 years ago so that we had these sort of reusable consumer credentials, we could rely on them, we could plug that in to what we're trying to do here, but we're not there yet. At least that was our impression several months ago, but I'd be interested to hear from other panel members.
So the good news is that this stuff now works, and it works at scale. And doesn't need to be too infringing. If I were to recommend what level 2.5 is, based on the data, it would be level 2 identity proofing and two-factor authentication. That is, and I would work to liberalize a little bit what the other factor could be. But even if we lived with the current NIST 800 definitions of the second factor, we could live with that. Verizon has got an offering that we call, and I know we're not here but we call this thing universal identity, and we predicted that this problem would come 7 or 8 years ago, and decided to get scale around a sort of seamless identity that doesn't require a smart card. All those other countries and the VA and so on carry a card. Anybody who works for many agencies in this town have these cards to get in. The Senate does, and the White House does, and all the military and armed services do. But you can't ask my mom to have one of these. And besides, even if she did, there's no place to plug it in on her computer, right? It doesn't interface very well. And most countries that have them don't use them for identity online either because of that second step that's required, the identity card reader that hooks into the computer or the iPad or stuff. It is too hard. But there are plenty of other things. And LOA 3 or 2.5, the way I defined it, is certainly available to get my mom to do that. The questions of her can be done pretty easily, and they're pretty lightweight. They aren't asking you the square footage of your house. Right. They're pretty straightforward things. That only needs to be done once. We already have a way of sharing identities. Symantec and Verizon and all the people who do certificate-based stuff already share them all through the Federal Bridge anyway, and we already know how to trust each other. So there's this whole HIPAA concept that doesn't necessarily require the Federal Bridge, but that means we don't know how to share identities between the dozens or hundreds of HISPs that might be out there. The easiest thing to do is just say if it rises to the level of a Federal Bridge interoperable identity, then it ought to be usable by all these things, even if it is in NIST level 2.
So I think we were hoping to have a few minutes for some questions. Unfortunately, we won't be able to connect with Beth, but we'd love to sort of hear from you all what sort of questions you might want to ask of the panel. They don't have to be, they should be on identity management, since that's this is our identity management panel, but they don't have to be sort of limited to the Health IT Policy Committee or Standards Committee approaches to this. So you look like you're sort of springing up for... Just come to the mic if you would, so the folks on the web can hear.
So I'm going to represent the folks on the web.
Yay, thank you.
The first question from Twitter is more around the affordability of solutions for managing EPHI related to identity, especially for small providers or for nonprofits and things like that, if you could comment on that.
Yeah, I don't know if our panelists do. This was definitely an issue that came up in the policy committee deliberations, and in fact, it was one of the questions that went out in the request for comment that was part of is preparations for stage 3 that the policy committee put out, and we got a lot of feedback from people. We're not ready, essentially, for LOA 3. We don't know how much this is going to cost. We don't think the providers are ready to adopt it. All while we have, sort of the VA representatives on the committee going, are you kidding me? Like, we have to, we're already at level 4. Like, this is not an unreasonable set of expectations.
I will say that there's been a flurry of activity in the last year and a half, federal bids and things. The New York bid that SureScripts and Verizon did is one of them, but almost all states are working on this. Everybody who has a health insurance exchange in their plan is working on something to do with identity. The HHS and the Medicare is working on that. So is IRS, so are others. So there's a ton of activity. And I can tell you that whereas these smart card-based identities have historically cost more or less $100 per person, and at high volumes have gotten down to $40 a year, something like that. These new ones we're talking about are selling in the market for the past 2 years for $5 or $8 or $10 per user per year, and at very high volumes under $2 per user per year. So we're seeing, and if you think of that, if you've got a 1,000-person practice, and it costs you $10, it would be on the high end. It would be a $10,000 insurance, thing for security. That falls in line with what you're paying for antivirus or firewalls or whatever anyway. So it doesn't seem unreasonable. I think these prices are now, not just Verizon, but the whole market responding with prices that work and meet the standards we're talking about in the range that feel like they're affordable.
So I would agree with that. I think the other thing we need to be cognizant of from a policy perspective is not just the cost of that technology, but we're also an industry where do the technologies need to be accredited by organizations? Do you have to be accredited by multiple organizations? So we go through our annual risk assessment. We're ENAC accredited. We're Direct Trust accredited. And so you can start seeing those costs starting adding up for vendors. So, we need a rational system in terms of accreditation that can be relied upon, again, by multiple people. I go back to the DEA experience. Again, the DEA rule was much more than just the ID proofing, but the DEA estimated the cost to get what's called a Section 1311 audit at about $15,000. It's actually coming out to about $30,000 to $150,000 an application. That's a heavy cost for a vendor to have to pay. So there are those costs that I think we have to be mindful from a policy perspective.
Thank you both very much.
Could you comment on discussions that you might have had about proxy access for those family members that take care of either children or the elderly that are managing health for identification in portal?
You're talking about parents and identifying their kids, that sort of thing?
Right, or elderly that are being managed by children.
Yeah. We did not take on that issue in the first round of recommendations on this. I don't know, Walter, did you guys?
No, we didn't either.
Yeah, but we knew it was there. And one of the things that sort of stopped us in our tracks, at least initially, was the fact that there's so much state law play with respect to the topic of who can access a record on behalf of a patient. So minors' rules tend to vary across the country. So at what point do minors have their own rights to the portal versus when is it the parent who has the right to the portal? Similarly, with respect to adult children accessing the information of their parents or some other family member or friend, frankly, that they're taking care of. When do they become the personal representative with the right to that data is not just a federal law issue. In fact, state law plays a heavy role in that. And given that our role is to make recommendations to a federal agency, that it sort of seemed like one of those places where we probably couldn't resolve it for all 50 states. Having said that, it came up yet again on the Tiger Team call just the other day. So it may be on our agenda, but it's an incredibly important issue. Right now the providers are going to have to figure it out for themselves based on their own whatever legal regime they're in, which is.
And I agree completely with everything you said. In the universal identity system that I mentioned, there's this notion called attributes, which are carried for every single human being. So we currently have a directory of 2.6 million providers. These are anybody who could write a prescription in America. And although only about 40% of those providers have ever touched the system, the other ones are pre-populated. So this is already installed. But the notion of an attribute allows us to keep track of, for example, my elderly mother's permission, HIPAA permissions, or access permissions. They're both already pre-written in the technology that say it's okay for my son to, or my daughter, or my neighbor, or whoever, to access this record. So the records are written in, the fields are built, and the technology is there to handle this. And what we see is, what we think is going to happen, by the way, the same thing happens when the secretary really logs in instead of the doctor. Right, it's very, very common for the secretary or the administrative assistant to be the person logging into the insurance company or Medicare or whatever and claim to be Dr. Betty Smith and get the transactions done. We can't expect every single application to be able to deal with delegates like that on day one. But the intermediary systems that we and others are building allow for Betty Boop, the administrative assistant, to have a permission from the doctor that says Betty Boop can act on my behalf for the purposes of this. At least a log is kept. We know it's really the right person. We know the relationship was right. We know the permission was right. And we know the HIPAA stuff is right. Yeah.
Yeah, so I think we're going to probably wrap up our session. Thank you.
I just queued up Walter for the close.
Thanks. So, yeah, I just wanted to thank you, everyone, for joining us into this session. And apologies again for not being able to bring in Beth from the VA, which actually has quite a bit of experience, certainly on handling within the population of the VA, both the patient as well as the provider identity. But I think this is truly one of the most significant issues that we're going to face moving forward. The challenge, and now speaking as a large integrated delivery system with over 20,000 physicians and many employees, as well as over 9 million members, it is a very complex issue. Not just internally to maintain the integrity of the identity of both the provider as well as the patient, but more importantly, the really scalability and the interoperability of the identity across systems outside of Kaiser. So that is really, I think, needs to continue to be the focus of further discussion. We are at a point where I think it's certainly very, very early to expect that there will be strong directive regulations that will define specifically how this will be done, because it's again early to define that. But in any case, I wanted to just thank our panelists, certainly our members of the discussion table here, as well as certainly OCR and NIST for inviting us to participate in this. And Devin.
Thank you all very much. I think Kevin's bringing up your next speaker, so we appreciate the fine audience. Thank you.
Thank you.